Chapter 4 Attention, Concentration, Orientation and Sleep. Keywords to be discussed in this chapter: attention, concentration, sleep, hypersomnia, parasomnia, and hypnosis. Attention is the active or passive focusing of consciousness that enhances some information and inhibits others, thereby allowing us to select some information for further processing. Attention, awareness, and concentration. Attention can be active, which is top-down in nature, or passive, which is bottom-up. The central feature of attention is its limited capacity, that is, only a definite processing activity can be carried out at any given time, which is usually tested by digit span test, but is prone to influence by fatigue, mood, and brain injury. Components of attention include orientating to sensory events, detecting signals for focused processing, and maintaining a vigilant and alert state. It is important to recognize that knowledge, prior beliefs, and goals and expectations can alter its speed and accuracy. There are four other aspects of attention. Focused or selective attention refers to the capacity to highlight one or two important stimuli or ideas while suppressing awareness of competing distractions, which is also known as concentration. The test called serial 7s is usually employed to test this. The second is sustained attention, also known as vigilance, which involves the ability to maintain attentional activity over a period of time. This is usually measured by vigilance tests. The third is alternating attention, which allows for shifts in focus of attention and tasks. And the fourth is divided attention. It is the ability to respond to more than one task at a time. Automatic cognitive processes exist in parallel with those that require attentive processes and allow for the effortless extraction of features of a perception in a bottom-up fashion, whereas attentive processes allow the top-down processing of information. This table summarizes different aspects of attention and the definition. Alteration of the degree of attention. Attention is decreased in normal people during sleep, in dreams, hypnotic states, fatigue, and boredom. Organic states such as head injury, acute toxic confusional states such as drug and alcohol-induced conditions, epilepsy, raised intracranial pressure, and brain stimulations. And in psychogenic states such as dissociative disorders, depressive illnesses, and is a prominent feature in the hyperkinetic disorder. This slide shows variation in the level of awareness. Impairment of focused attention imply weakening of the determining tendency, which is the ability of a subject to focus on a small part of the field of awareness. This is a feature of mania, hypomania, and some organic states, and presents itself as a symptom of distractibility. Disorder of attention in psychosis. Subjective accounts of abnormal attention in early stage draws attention to a number of cognitive difficulties, including focus, sustain, disengage, and shift of attention, thereby feeling overwhelmed by information. This supports Broadbent's theory, in which he proposed a sensory buffer that allows only certain sensory data to pass through a filter for later processing, and that this filter prevents overloading. But according to John Cutting, the problem is heightened attention rather than the proposed malfunctioning of sensory buffer. He used the term lures to describe features of environment that seem to hijack patient's attention. In cognitive neuroscience terms, the patient is excessively liable to passive attentional capture, in addition to problems with disengaging and shifting attention. Similarly, in mood disorders like depression, attention can be enthralled to negatively valued features of the individual's inner or external world. Cutting argues in mood disorders what lures the individual's attention are people and not objects, in contrast to skills. HEMI-attention. This includes a number of neuropsychiatric conditions such as unilateral neglect, anisodiphoria, which is the lack of concern about hemiparesis, defective appreciation of hemiparesis with rationalization, denial of hemiparesis, and unawareness of hemiparesis, that is anosognosia. Various cases of unilateral neglect and anosognosia emphasize that neural systems underpinning attention to both right and left visual fields are probably controlled by the right hemisphere, whereas the dominant hemisphere only oversees the contralateral visual fields. Orientation. It is the capacity of an individual to accurately gauge time, space, and person in his current setting. Orientation in time is labile and is readily disturbed by rapt concentration, strong emotion, or organic brain factors. This can be mild, that is, inaccuracy of around half an hour for the time of the day or duration of the interview, or moderate, which is inaccurate day of the week, year, or period of the day, or severe, in which the season of the year is not known correctly. Orientation in space is disturbed later in the disease, and when clearly established, is usually evidence of organic mental state like earliest signs of dementing processes. Disorientation of person occurs at the very last stage of organic deterioration, and the patient might fail to remember his own name. Delusions that mimic disorientation. Delusions of misorientation is usually a part of detailed delusional world and differs from disorientation due to organic causes, which is usually associated with organic features such as lowering of consciousness, or disturbance in memory. Dissociation and disorientation. Dissociative disorders may have apparent disorientation that mimics disorientation due to acute organic brain syndromes. Careful examination may, however, reveal discrepancies. For example, disorientation for a person may be much more marked than time or may be bizarre to an excessive extent. Sleep disorders. Mental illness may cause and manifest as sleep disturbance. Disturbed sleep may precipitate psychiatric syndromes, or the two may occur together but independently. The International Classification of Sleep Disorders subsumes 85 sleep disorders into 7 categories, including insomnias, sleep-related breathing disorders, hypersomnias not due to breathing disorders, parasomnias, sleep-related movement disorders, other sleep disorders, and isolated symptoms. 5 stages of sleep are identified using EEG and electromyogram of the external ocular muscles. The first stage is non-rapid eye movement sleep. REM and non-REM sleep alternate with a period of 90 minutes. Non-REM sleep accounts for around 75 to 80% of sleep, and REM sleep accounts for around 20 to 25% of sleep, occurring in 4 to 6 discrete episodes. It is also associated with dreaming. Insomnia. Insomnia is defined as a complaint of dissatisfaction with sleep quality associated with difficulty initiating or maintaining sleep or early morning awakening. It can be defined in strictly formal terms, which stipulates that there must be greater than 30 minutes of sleep onset latency or wake time after sleep onset. It is more common in women and older people and is among the most frequent symptoms in anxiety-related and affective disorders. Late insomnia or early morning awakening is particularly characteristic of the depressive phase of affective disorders. With insomnia, intermediate stages of light, restless sleep occurs, and these are often associated with abnormal experiences in the sleepy state, such as hypnagogic and hypnopompic hallucinations. Sleep drunkenness is confusional arousal from non-REM sleep, in which confusion and disorientation or even slowed speech and mentation might occur in some. Hypersomnia. In hypersomnia, the defining characteristic is daytime sleepiness. In Kleine-Levin syndrome, attacks of somnolence occur, usually in adolescence. The patient is arousable, eats voraciously, and has marked irritability. It is characterized by relapsing remitting episodes of hypersomnia, cognitive impairment, apathy, derealization, behavioral disturbances, and psychiatric disturbances such as delusions and hallucinations. Boys are more frequently affected than girls. The first episode of hypersomnia is often triggered by an infection, with relapses occurring every 1 to 12 months, for a median of 14 years. During episodes, EEG might show diffuse or local slow activity. Functional imaging studies have revealed hyperactivity in thalamic and hypothalamic regions as well as in frontal and temporal lobes. Narcolepsy is a form of hypersomnia and can occur either with or without cataplexy. Narcoleptic attacks are short episodes of sleep around 10 to 15 minutes each that occur irresistibly during the day. They usually begin during adolescence and persist throughout life. Hypnagogic hallucinations, especially auditory, and sleep paralysis may also occur but are less common. It is associated with short sleep latency and sleep onset REM periods. There is usually no structural brain disease present. In the Pickwickian syndrome, also known as obstructive sleep apnea, there is profound daytime somnolence which is associated with gross obesity and cyanosis due to hyperventilation. Sustained drowsiness may occur with organic lesions of the midbrain or hypothalamus from various causes. The most important conditions giving rise to secondary hypersomnia are brain tumors, neurosarcoidosis, and Niemann-Pick disease. Hypersomnia may also occur as a psychogenic symptom, especially in neurotic disorders. Parasomnias. Parasomnias are disorders of arousal and stage transition that consist of abnormal sleep-related movements, behaviors, emotions, perceptions, dreaming, and ANS functions. Sleepwalking consists of series of complex behaviors arising during slow-wave sleep during the first third of the night. It is more characteristic of children than adults and males than females. Activity is usually confined to aimless wandering and purposeless repetitive behavior for a few minutes. The sleepwalker may reply monosyllabically to questions, and there is little awareness of the environment, but injury is unusual. Frequently, there is family history, and enuresis is often associated. Night terrors also occur in deep sleep, early in the night, and often in the same individual who sleepwalks. Intense anxiety is manifested, the subject may shout, and there is rapid pulse and respiration. Usually, there is complete amnesia on waking. It's different from nightmare because the latter is a type of dream occurring in lighter states of sleep and is remembered vividly if the person wakes up immediately after the experience. The law calls this sane automatism and states a person who commits a criminal act while asleep is not conscious of his actions and cannot be held legally responsible for them. Sexsomnia is less known and involves sexual behavior during sleep. It is also a part of non-REM parasomnias. Dreams. Dreams are highly complex experiences and so far has defied adequate analysis and explanation. But there are psychiatric theories concerning origins of conflict, a topic that was extensively written about by Freud. Phenomenology can make limited contribution to our understanding of dreaming, as it is concerned only with what is conscious. However, certain characteristics can be described. For example, the margin between self and not self becomes indefinite. The sense of time is lost. There is often loss of control of circumstances and of temporal, spatial, and psychological association between events. The dream is often like a group of short excerpts from very different films. There are also dream images, elements that do not occur in normal waking state. They are not delusions, hallucinations, false memories, or other abnormalities of perception or ideation. In some cases, areas of conflict that have precipitated the distress will be revealed in the contents of the dream, like PTSD. Hypnosis. At one extreme, hypnosis is considered to be a very different state of awareness from the normal waking consciousness. At the other extreme, it seems identical to hysteria, involving self-deception and production of alternative symptoms or behaviors to solve a problem, or even if no conflict is present. It is defined as a psychophysiological state of attentive receptive concentration, very similar to trance state. But there are no EEG findings to distinguish hypnosis from other states of relaxed wakefulness. It involves three interconnected factors. First is absorption, which involves the tendency to engage in self-altering and highly focused attention, with complete immersion trance experience, such that people often choose to ignore environmental cues. The second is dissociation, which is the capacity to separate mental processes so that they seem to occur independently of each other, and thus a past memory may be dissociated from current events. The third is suggestibility, which refers to the ability of a subject to be easily influenced because of the heightened responsiveness to social cues, including instructions given during the hypnotic trance. Hypnosis has been used for the control of pain, in the treatment of hyperemesis gravidarum, and especially in the control of anxiety. Characteristic of hypnotic state. The subject ceases to make his own plans, attention is selectively directed, reality testing is diminished, and distortions are accepted. Suggestibility is increased, the subject readily enacts unusual roles, and post-hypnotic amnesia is often present. There is now emerging evidence of the underlying neural correlates of hypnosability, pointing to greater functional connectivity between the executive control region of the brain, that is the left DLPFC, and the salience network composed of the dorsal anterior cingulate cortex, anterior insula, amygdala, and the ventral striatum, which are involved in detecting, integrating, and filtering relevant somatic, autonomic, and emotional information. fMRI during mental imagery shows signal increase in left superior frontal cortex, the left anterior cingulate gyrus, and the left thalamus, whereas during movement performances, the superior frontal cortex and the anterior cingulate were activated, and during motor imagery, the thalamus was activated. Interestingly, these areas represent central nodes of the salience network, linking primary and higher motor areas, suggesting hypnosis enhances motor imagery.